outside of the paclitaxin, which is an injection, most of our clinical trials up till now have been drug therapy trials. And so we know that gene therapy essentially is not them. So gene therapy is not something that we're going to do on a daily basis as a source of treatment. It's not a therapy that's designed to wash out, which is why we have drug therapies. We continue to take the medication because it eventually will go away from the bodies. And one of the challenges with gene therapy when we think about how to design it, especially in a disease like FA, is we need to think about designing a therapy that can be given to people that are already diagnosed. So how does it change the course of disease in people that already have the diagnosis? And what does it look like in treating people who, in childhood particularly, who might be diagnosed genetically but haven't yet had any onset of symptoms? So we're really trying to think in gene therapy about the continuum of disease in the context of FA. So what is gene therapy? And I love this slide and this statement because it is the most simplistic thing really to think about. And when I give you some timelines, you'll realize how complicated this process has been. So very simply put, gene therapy is the process of adding genetic material into cells to compensate for genes that aren't working. Let's do that. More importantly, they also define this, and this comes a little bit from the FDA website. Gene therapy is defined by the precision of the procedure and the intention of therapeutic effect. And that's under the guidance of where some of this approval comes from the FDA, is gene therapy is separating out from something of introducing genetic material when we do an organ transplant, for example. That is introducing genetic material into somebody, but it's a very different process in that delivery, and it's a very different intent in terms of the therapeutic effect. So let's quickly go through some gene therapy milestones. First conceptualized in 1972, first clinical trial in 1990 at the NIH for severe immunodeficiency. The girl had that treatment. But then if we look from there, in 30 years, between 1989 and about 2018-19, there were more than 2,900 gene therapy clinical trials conducted. Most of them is phase 1. That's a lot of clinical trials compared to what we have approved right now. And when we think about that, it also emphasizes the complication of developing these therapeutic methods. We've learned a lot in that 30-year span. We've learned a lot about the safety. So that was some of the bigger issues that occurred when gene therapy was first tried, is that it wasn't safe for everybody. We were doing more harm than good. So it became, what do we learn about improving the safety and improving the efficacy? So the big ones in 2017 in December, Walther, we're going to talk about this in a little bit at the end, developed by Spark Therapeutics as a team that academically out of Chapin and Penn formed the company Spark Therapeutics, and they had an FDA-approved treatment for a genetic form of blindness called Leber's congenital amaurosis. And then the one that most people are a bit more familiar with in our realm is in May of 2019, Zolgensma, developed by Vexus and a little bit through Novartis, was approved for the treatment of spinal muscular atrophy. Gene therapy is effective for single gene diseases. That's where we currently are, and FA fits under that. So we call single gene diseases monogenic. So one gene causes the disease. And some of the other examples here on the slide: cystic fibrosis, hemophilia, muscular dystrophy, sickle cell anemia, and obviously FA. And all of these are undergoing experimental treatments, trials, development phases to try gene therapy as a treatment. So how does the functional gene get to the right cells? So there's lots of things that we can do in the laboratory. but we've pretty much learned that evolution outweighs any brilliant scientific mind. And so what we really realized is we've got viruses. Viruses are really, really good at getting into human cells. And so what we have is, these are just some examples of viruses. And you can see HIV. These are all examples of diseases that we know that are caused by viruses. So we know how viruses function. And in terms of choosing a virus, obviously we want to choose a virus that even if we engineer it and something goes wrong, that it doesn't cause a problem. So, for example, using something like HIV or Ebola, we could re-engineer it to possibly work in a gene therapy. But if something doesn't go well, the opposite is pretty bad. So, the one that's been chosen for most gene therapies is the adenovirus, which is the type of virus that causes many common colds or upper respiratory infections. So if somebody has an immune reaction to the virus that's used, the outcome is not going to be catastrophic. And we can control for it even better by re-engineering it. So now we have these viruses that we use called AAV, which are adeno-associated viruses. So it's a form of the adenovirus, but it's just been engineered a bit. And essentially what that engineering took care of was you have this outer shell, and the yellow bubbly look is called the capsid. And the capsid is what kind of identifies the target cell where the therapy needs to be delivered. What we also engineered is we removed all of the virus particles. So when the virus gets to the cell, it's no longer delivering virus into the cell, it's only delivering our therapeutic gene of interest. And some of the engineering that has occurred has developed and identified, some of it's been developed, some of it's just been identified, is that there are types of AAVs that can target specific cell types. And this is just a brief example: brain, muscle, retina, heart, lung, liver. So some of those AAVs, and you'll sometimes see that, and I just wanted to give this brief slide so that when you see some of the gene therapies coming out for FA, you may see that they're using the AAV5 or AAV9. It's just a specific type of adenovirus that has been chosen for that particular therapy, but it's still going to be delivering the same gene. And so some of this re-engineering, as listed on the slide, they're not pathogenic. So when I talked about HIV and Ebola, that causes severe disease, whereas the AAVs are much, much less pathogenic. They're less immune, so the body doesn't see it so much as foreign as some other genetic material that might, or other viruses that might be present. And it's shown, in all those clinical trials in the last 30 years, it's shown a pretty strong safety signal. Also, and this is what people often ask, it doesn't, when that DNA is delivered into the cell, it doesn't integrate or change your DNA that's already there. So that's very, very important, and that has a lot to do with removing the viral DNA and just only putting in our therapeutic gene. So there are basically two concepts in gene therapy. The first is the AAV delivery system. So that's our virus. That's the capsid, the yellow bubbly outside that I showed you. And then inside, we have to construct the instructions, or what we call the cassette. And the cassette contains the gene of interest and the instructions. And what you'll see here is, let's say the orange part, that's our gene of interest. So that would be the frataxin gene. These two ends, well, let's start with the red area called the promoter. That's essentially a signal that tells the cell when to turn the gene on and start to make it. You kind of, where this X is on the back end, is an area that says this is where the gene stops. So where does it start? Where does it get turned on? Where does it stop? And then the sequences on either end, called this ITR, is essentially a signal that once the set is in the cell, it helps figure out how to package it and replicate it. So we don't want it to just be sitting there with a start and a stop. We want it also to figure out how to keep making it and continue to make that functional protein in the cell. This is a more simplified version of what I just showed you. So essentially the two components of gene therapy are like a letter, which is your delivery system, the envelope, and the letter of your instructions. So the AAV is the delivery system, the envelope, gets into the cells, and then that opens up, and the letter with the instructions, therapeutic gene, is released and becomes functional. And this is essentially what we expect to happen in the cell. This shows you a little bit of this, is that DNA needs to become RNA, needs to become a messenger that gets translated to the protein. So the overall goal of gene therapy is to get the DNA into the cell so that it can function how it should have been functioning all along, was to actually make functional protein for frataxin. So how do we get that gene therapy into the body? I'm going to go through a couple of methods. The first ones that I'm going to tell you about are in vivo. So in vivo means that we're taking it and we're putting it directly into somebody's body. And the first method is the intraparenchymal, which is basically a direct brain injection. So again, this is a bit simplified because if you're going into the brain, there's a bit more of a surgical procedure, not just a simple shot with the syringe. That was easy to put on the screen. But essentially, we can figure out if the therapy is developed to target the nervous system, and specifically the cells that are dysfunctional, if that's the word, in FA, specifically the dentate nucleus near the cerebellum, then we want to get that therapy directly into those cells. And so that would involve what we call intraparenchymal, and would be a direct brain injection. Another way to get it into the nervous system is intrathecal, and that's injecting the therapy directly into the spinal fluid. So it can reach areas of the nervous system, but depending on what virus is used and whether the therapy is able to cross the blood-brain barrier, there's a possibility that it will reach areas of the nervous system, but won't get all the way into the brain. So again, it depends on what is that therapy that is being developed, what is the target tissue, will also influence how the delivery method is chosen. And then the easiest one is basically an IV. So hook up to a vein, pump it in, and again, this is more what we call systemic. It's going to just enter the bloodstream, and it's going to be designed to find the tissues that it needs to target, but it might not necessarily bypass the blood-brain barrier and get into the brain. When we talk about these different delivery methods, it also implicates how much virus particle. So when they calculate the therapy, they calculate how many virus particles per growth kilogram, so how much do you weigh, that needs to be delivered. And the less specific methods, the higher the amount of viral load that you're going to need. So a direct injection into the dentate nucleus is probably going to require a lower viral load than if somebody is getting it delivered through IV. So again, these are all choices that have to be made when these gene therapies are being developed. This is an ex vivo. So in vivo is directly injecting into the person. Ex vivo is we're going to remove somebody's cells, in this case stem cells. We're going to take them out of the person. We're going to essentially perform the gene therapy, but in a petri dish or in the laboratory. We're going to enrich those cells as they grow and select out those cells that are definitely producing and making the protein of interest. And then we're going to take those cells and put them back into the person. So what are the benefits of doing an ex vivo versus an in vivo? In vivo is going to get you more directly to the target tissues that you want to get to. Ex vivo, because you're using the person's own cells and you're putting the cells back into the person, there's less of a chance of seeing an immune effect. And you can be able to enrich the population of cells to get back, that you're giving a population of stem cells back to the person that has been enriched to guarantee the delivery of that treatment. The downside is that we don't always know. It's going to be harder to get it directed to the tissue of interest. We have to depend a bit more on the stem cells getting to the right tissue. So there's a lot of trade-offs in terms of choosing which method of delivery. So why should we consider gene therapy for FA? As we talked about, FA is a monogenic disease. So we got that on the list. When we're talking about these viral capsids, they can hold a certain amount of DNA. So we actually have to know how big is the gene that we want to get inside the virus, because there's a capacity where you cannot get some of these other genes inside the capsid. It just can't hold it. And the frataxin gene is small enough to fit into these AAV vectors. So that's good. FA is a condition of protein deficiency. And what that means is the cells just don't have enough frataxin. We don't have a situation where abnormal frataxin is being made in people that have the 2GA repeat expansions. And so we're not going to run into a problem that we put normal protein into a cell and the abnormal protein is going to interfere with the production of the normal protein. So we already have normal protein in the cell, it's just not enough. And all we need to do is create more frataxin protein in the cell. And even, again, too, when we're developing these therapies and we're choosing the vector that can be used, there are discrete tissues. We know what tissues, for the most part, need the increase in frataxin protein the most. And we can target that, or we can think about if we get it systemic, does it find its way to the right tissues? So, when will gene therapy be available for FA? Good question. So, we've been talking about gene therapy for FA for at least 5 years. So, what have been the challenges to the development? Choosing the target tissue. Where do we want to start? What's the greatest need? And some of those decisions, once we make those decisions, then it influences the selection and the development of the AAV capsid. Which one are we going to choose to get to that tissue type? And then we have to make sure that the cassette, or the instructions that we put inside, are the instructions that we need so that it functions in the cell. First we need to, so let's say we've got the first bullet point done. Then we need to generate sufficient cell and animal model data. We cannot go just from, we think this works, let's try it in people. We have to show enough data that it actually works in a cell model and then an animal model. This is also, I think, specifically, Dr. Payne talked a lot about this with the frataxin and the manufacturing and what goes into that. And that's all part of designing a clinical trial. So it applies to gene therapy in terms of the manufacturing requirements. Can we scale it up? If we make enough to put into a cell, that's all great. But remember we talked about, we're calculating viral load now per kilogram weight of somebody. We're needing to scale this up. And as we scale it up, we need to make sure that it's still safe. Nothing happened in that manufacturing process to change it, to make it pathogenic, for example. We need to make sure that it's truly what we think we're making, we are actually making. We need to know that it's pure, that there's not any other contaminants in there. And we also need to show that it's strength. So remember when I talked about ex vivo and selecting out cells that are enriched for providing the instructions or the treatment. The same thing can happen as you're growing up these viruses in large quantity. We don't want the virus to kind of get rid of its instruction. So the strength is how we reach the quantity that we need, but potency. Does it actually contain enough of the treatment to deliver to a person? And this is something that FARA is working on in conjunction with our partners who are looking at gene therapy, is developing an adequate potency assay so that we can document out of that manufacturing that yes, we have a viable, safe product to be able to use in the clinical trials, and even after when we get to the point of it being approved, that potency assay is still important. And then after all of this, then we can begin to prepare the investigational new drug application for the FDA to review. So there are many, many challenges to think about before we can actually get approval to start a phase 1 trial. Additional challenges for FA, it's a multi-system disease. So we need frataxin in a lot of different tissue types. And currently, the way that the gene therapy is designed is you have one AAV vector, essentially with one route of administration. So there's some decisions making, again, as I said, where is the need greatest? Where do we want to try to have the greatest therapeutic effect? And then studies still are being done to determine what percentage of cells need to be fixed to actually see that therapeutic effect. So what level do we need to increase the frataxin to actually document that there's an outcome that we want to change the course of the disease? So, saying all of those challenges, now I'm going to show you the partnerships that we have, some of the development that we're doing in gene therapy, and it's really to document that these challenges exist. We have a lot of players in the field, and that tells us that these partners are confident that we can overcome some of these challenges, and all of these challenges, hopefully. So PTC Therapeutics is probably the furthest along. They're using the AAV5 vector. It will involve a direct brain injection to the dentate nucleus. They're at the investigational new drug stage where they're doing studies to get to the IND. They expect to file that IND this year. And we're working on developing some educational modules to get the FA community ready to think about making that decision of whether to enroll and participate when the IND is approved. University of Florida, in collaboration with Aventi Bio, is using an AAV9. They're talking about an IV and intrathecal mode of delivery. They're also at the IND enabling studies. So that means that they're just working on data to be able to submit to the FDA. They also expect to file an IND in 2020. Their approach includes an immune suppression. So they're going to think about suppressing the patient's immune system so that there's less immune response to the AAV. And that might lead to the possibility that if somebody needs like a booster therapy shot, or a simple way to put it, that might be able to be done down the road. Anexus and Novartis are also working with AAV. Their delivery method hasn't yet been disclosed. They are working on IND enabling studies, and they're at the stage of establishing the animal models. Voyager, in collaboration with Neurocrine, also AAVs. We don't know their disclosure. They're in preclinical, so they're still selecting their lead candidate. So they're prior to any of the animal studies. Pfizer is an AAV9 IV delivery, also preclinical. They're working on the animal model studies. Stride Bio, in collaboration with Takeda and Sarepta. Stride Bio is developing kind of their own viral vector, looking at ways to even further decrease immunogenicity without doing immune suppression. And their likely target is going to be the central nervous system or possibly systemic. And they're still in the discovery phase, so they're the earliest in the field. So let's briefly just talk about how phase 1 trials might be designed. And I want to give you what we've learned from the 2 that have actually been approved. So Leber's congenital amaurosis, that's the genetic form of blindness. The sponsor was Spark Therapeutics. They essentially had 2 start dates because we have 2 eyes. And they did 1 eye and then started that in 2007. And then patients that were enrolled in 2007 were able to enroll in 2010 and have the therapy applied to the other eye. In this study, one of the eligibility requirements was that the patients could actually document, there was documentation in those eyes that there were still active retinal cells. So even though there was vision loss and essentially what we would be classified as blindness, that they had cells that were expected to be rescued by the therapy. They enrolled 12 patients. In the phase 1, they had no placebo control, so we called it open label. Everybody knew that they were being treated. It was a subretinal injection, so injection into the eye. It was done at CHOP, and in this case, I'm not going to go in the whole retinal dystrophy field. There are probably over 200 genes that cause genetic blindness, and so this therapy was very specific on one type and one mutation type. So it was a very narrow eligibility in terms of what kind of LCA you had diagnosed, and enrolled patients age 8 to adult. In the phase 1 protocol summary, there were 3 dose escalations. So again, that's something else that we know about gene therapy when we get to the trials. The phase 1 is usually what they usually refer to as low dose, intermediate dose, high dose. And they test out those 3 doses to see what's safe and what do we begin to see makes a difference in therapeutic outcome. By the time they made the decision to do the injection of the second eye in 2010, they had chosen a specific dose out of the 2007 study. So the second eye just got a single viral load. This is the other thing to take home message with gene therapy. Short-term safety was evaluated over 2 to 5 years. So we're not talking months in these trials, we are talking years to be able to look at, right now, this is the requirements that we have with looking at safety. And then each disease is going to have its own efficacy assessments based on what can be documented of a change and when that change can be documented. So here they were looking for changes in visual acuity, and they had very different methods of being able to document that. This is the other requirement that's right now for gene therapy by the FDA. The FDA would like, after somebody is dosed with gene therapy, they would like them followed for a minimum of 15 years. So these patients in the LCA phase 1 are going to be monitored 1 time per year for up to 15 years. The phase 3 protocol started in October of 2012. They did both eyes at the same time. More patients in this, and they did do a placebo-controlled study. The nice thing about this study is they, after 1 year, they offered all the placebo patients, the 9 patients, if they wanted to cross over into treatment, and all of them accepted that. They're still doing efficacy assessments, and again, these patients in this phase 3 will also be monitored for up to 15 years. Luxturna for LCA, so that was the drug name that came out of these trials. It was Luxturna, was approved by the FDA on December 19th, 2017. So a lot of good data started in 2007 and got their approval about 10 years later. So let's quickly go through SMA. That was the sponsor for Avexis. The start of this phase 1 trial was May of 2014, completed in December of 2017. They enrolled 15 patients. There was no placebo control, so it was open label. The delivery was IV, and they did 2 doses a lower dose, where they enrolled 3 patients on that lower dose out of the 15, and 12 of the 15 patients were on a higher dose. And there was about a 3 times difference from low dose to higher dose. One site at Nationwide Children's Hospital in Ohio, eligibility was that the child had to be diagnosed with SMA by 6 months of age. So SMA type 1, you can almost see it at the time of birth, or you can suspect it. There is genetic testing to confirm it, but very, very, very early onset for this disease. And children often don't survive to a year of age. So you're looking for very quickly changes in the outcome. Short-term safety was evaluated over 2 years. I'll just show you that this is the process. And I show you this level of evaluation because we have to think that this might be a reality for FA. So they had to be followed every 7 days for 1 month. Then that went to 1 time a month for 1 year. And then they were able to go to follow up for 4 times a year for 1 year. So again, a lot of clinic visits for these kids. They looked at safety and efficacy. So they essentially decided that when a child was 13.6 months to 13.5 months old, they should see some efficacious therapeutic effect. And they had assessments for looking at that, documenting that. And then they did an additional 2 years of assessments post-dose. And again, they'll be monitored for up to 15 years. So this got out of the phase 1, and that's all that was required. The results were remarkable enough that they were able to go to the FDA, and Zolgensma was approved in May of this year, or last year, May of last year. So what have we learned from some of the trials that have come before? When we think about gene therapy that might be developed for FA, it's going to be choosing the right patient. So if we're going to document a change in course of progression of disease, what does that look like in terms of the patients that we should enroll versus, do we only pick patients that are ambulatory? Do we look to see where patients are in progression of disease? Are we going to look at cardiomyopathy only? So there are lots of things that are going to go into that eligibility criteria based on the therapy that is developed. How many participants are needed? We heard today about the power. Like what's the number of patients that have to be enrolled to be able to document a therapeutic effect? And that's going to be influenced by what tissues and outcome measures we're looking at, and what kind of dose escalation we're looking at, how long we need to do the safety and efficacy measurements. Number of centers for enrollment. That's going to be influenced mostly by the mode of delivery. So if we need people that have neurosurgery experience with gene therapy, that's probably going to limit the number of sites we can have, where the therapy is given by IV. That could expand the number of centers. Again, too, it depends on how many participants. We might normally need 1 center if we're only going to do a few number of patients. And then the length of follow-up. So again, the take-home message here is that with gene therapy, the FDA right now is requiring a much longer follow-up to document safety and efficacy, whereas some of our drug trials, we've been able to complete them in about a year and have data that's sufficient to submit. Gene therapy is asking for a much longer time to document safety and efficacy. That's all I have. Can I answer any questions?
Susan? The length of follow-up is, thank you, the length of follow-up, your last slide there, is potentially after approval. Is that correct?
It's both. So once therapy is administered, what's the length? So the length of follow-up in terms of after dosing, how long do we have to document that it's safe and that we're seeing a therapeutic effect? But even after that, the FDA, when it's approved, all of that, they still want, right now, they want about 15 years in follow-up data because gene therapy is still so new.
But once it's approved, everybody or whoever qualifies would get it, but they then would be
But we still would
followed.
ask, anybody who gets the therapy, we would still ask them to come back for 15 years of follow-up.